So this is chapter 16, where we're going to focus primarily on the autonomic nervous system, but we'll also briefly mention some other higher order brain functions. So we'll start with an introduction to the autonomic nervous system. So I'm going to tell you the difference between the autonomic and somatic divisions of the nervous system, as well as the differences between the sympathetic and parasympathetic divisions of the autonomic nervous system. So first, let's look at the differences between the autonomic and the somatic divisions of the nervous system. So these are both motor divisions of the PNS. So these are both part of those efferent pathways, which are taking commands from the brain down to the body. So both of these are motor divisions. The difference is the effectors that the commands are sent to. So with the somatic nervous system, the instructions are going to start up in the primary motor cortex, which is on that precentral gyrus of the frontal lobe, and it's going to send commands down, eventually reaching skeletal muscles. And we'll talk a little bit more about the somatic nervous system in chapter 15 next semester. The autonomic system, which is the focus of this chapter, starts in the hypothalamus. So if you remember, one of the functions of the hypothalamus was that it had the control centers for the autonomic nervous system. So that's where signals start in this case. And then the commands are sent downward to visceral effectors, which are your cardiac muscle, your smooth muscle, glands, and adipose tissue, which is a specialized type of gland. So, as I said, the focus of this chapter is going to be on the autonomic nervous system. And the autonomic nervous system is responsible for routine homeostatic adjustments that are completely unconscious. You're unaware of them. These are changes in heart rate, changes in the way your kidney functions and your digestive system, your breathing, your blood pressure. So these are all the routine homeostatic adjustments that lie just below your consciousness. So the autonomic nervous system does control visceral effectors. So as mentioned previously, this includes smooth muscle, cardiac muscle, and glands, including adipose tissue. And I'm going to go over the general pathway of information, and then when we look at the two separate divisions, we'll go into this in more detail. But as I mentioned earlier, you're going to start with a signal that originates in the autonomic control center of the hypothalamus. So you're going to have a neuron from the hypothalamus, and those neurons are shown in purple. The circles are the cell bodies, and then the lines coming down are the axons. So the hypothalamus neuron is going to talk to what's called a preganglionic neuron, and these are the neurons shown in red. So their cell body is going to be in either the brainstem or the spinal cord, and then their axons are going to go out into the periphery, and they're going to go to what we call a ganglion. So these yellow circles represent the autonomic ganglia. And remember, I mentioned to you earlier that anytime you see the term ganglion, it refers to a neuronal cell body that is outside of the central nervous system. So anytime you have a neuronal cell body that is not in the brain or the spinal cord. So we do have a neuron that is in these ganglions or ganglia, and that is the black neuron here. That would be called the ganglionic neuron. And then these neurons are going to have an axon that's then going to go out to an effector, and that axon is called a postganglionic axon. You may also see it referred to as a postganglionic fiber. So that's the general pathway from the hypothalamus to a preganglionic neuron to the ganglionic neuron, and then the information is going to go out through the postganglionic axon. So the autonomic nervous system is divided into two divisions. There is the sympathetic division, which is commonly referred to as your fight or flight response, and that is shown in this image. This is showing you the preganglionic neurons and postganglionic neurons in green. So that is your sympathetic system. And then you also have your parasympathetic division, which is your rest and digest system, and that is shown on the right side with the purple neurons, and again you're seeing both the preganglionic neurons, the ganglions, and then the postganglionic axons. So the two divisions have opposite effects. So the sympathetic division deals with emergencies, so emergency situations in which things have to be brought back to normal. And also the parasympathetic division deals with your normal resting conditions. So if you're not in an emergency state, then it's your parasympathetic division in control. There is a third division that is considered to be part of the autonomic nervous system called the enteric nervous system. And this division encompasses about 100 million neurons within your digestive tract. We're not going to spend too much time on it. We may mention it again briefly later, as well as next semester when we talk about the digestive system. So in this section, we're going to look in detail at the sympathetic division. And this is your fight or flight division, which deals with emergencies. So as we go through the anatomy of these divisions, keep in mind that in your textbook and even in these lectures, fiber and axon are interchangeable. I think your textbook uses the word fiber more often, and I sometimes flip back and use the word axon, so just keep in mind that they're both interchangeable. So as a quick overview of the sympathetic division, so we have our preganglionic neurons, which originate in the spinal segments T1 to L2. They originate in those lateral gray horns. And then, as we're going to see in a moment, we've got three different types of ganglia in the sympathetic division. And then, so the preganglionic neurons are going to run from the spinal cord to the ganglionic neurons, and then the postganglionic fibers are going to go from the ganglia out to the target organs. So again, notice that with the sympathetic division, the preganglionic fibers / axons originate in the thoracic and lumbar segments, so from T1 to L2. The chain ganglia, as we're going to see in a moment, extend the entire length of the spinal cord, so you actually have this type of ganglia that runs all the way down both sides of the spinal cord. And then even though the preganglionic fibers originate only in this section of the spinal cord, once you get away from the spinal cord and you have all of those branchings of the different nerves, so remember in chapter 13 we mentioned the ramus, right? You had a gray rami and a white rami. All these different ramus connections allow the sympathetic fibers to move and mix with a bunch of other nerves. And so in the end, all of your spinal nerves end up having some amount of sympathetic axons mixed in with them. So about 8% of each spinal nerve is going to end up being sympathetic axons. And as mentioned again, there are three types of ganglia, and we're going to look at those details on the next slide. So the sympathetic ganglia, there are three major types, and just before we go into those, let me note that the textbook made a mistake with this image. Whoever they got to draw this image put the anterior median fissure on the wrong side. So according to, you can see the dorsal root ganglion here, so this should be the dorsal side of the spinal cord. So this should be the posterior median sulcus, so that should look like this, and this looks like the anterior median fissure, and it should be down here. So just note that whoever drew this drew it wrong. All right, so the first type of sympathetic ganglia are the chain ganglia. And the chain ganglia lie along both sides of the spinal cord. So again, I mentioned that this one right here was the dorsal root ganglion, and then you can see this is a chain ganglion, this is a chain ganglion. They extend up and down in a chain along both sides of the spinal cord. So they look like a string of pearls running along both sides of the spinal cord. And so the neurons that originate in the chain ganglia control effectors in the body wall, the thoracic cavity, the head, the neck, and both limbs. The second type of ganglia is called a collateral ganglia, and there's three of them, and they lie anterior to the spinal cord. So again, this should be the anterior median fissure here, and the collateral ganglia lie anteriorly to the spinal cord. There are only three of these, and they control effectors in the abdominopelvic tissues and organs. So I'm not going to test you on the names of them, but there's the celiac ganglion, the inferior mesenteric ganglion, and the superior mesenteric ganglion. And then the third ganglia, there's just one, and it's the adrenal medulla. So medullae is plural. So if you look at each of the adrenal glands have two major components. They have a cortical region or a cortex, which is on the outside, and then the very inside of them is called the medulla. So this adrenal medullae in both of the adrenal glands is actually a modified sympathetic ganglion. And so you're going to have a preganglionic fiber that's going to run all the way to the adrenal medullae. And then in this case, your postganglionic fiber is going to be very short, and it's going to cause cells in the medullae to release epinephrine and norepinephrine. So direct release of hormones into the bloodstream. So let's look at the overview of the sympathetic division. So again, the preganglionic neurons are going to start between spinal segments T1 and L2, and they are going to run out to a ganglion. So most of the sympathetic ganglia are these chain ganglia, which lie on either side of the spinal cord like a string of pearls. Then you have these other three collateral ganglion, which are normally on the anterior side of the spinal cord. They have them wrapped over to the side here, but here's one, and here's one. And then, of course, your one exception where you have the adrenal medulla, which is also a sympathetic ganglion. So if you'll notice, all the preganglionic neurons in this image are red. And also notice that for the majority of them, they're pretty short. So a preganglionic neuron runs from the spinal cord to a ganglia, and because the sympathetic ganglia are normally very close to the spinal cord, so the chain ganglia are right next to the spinal cord, the three collateral ganglia are right underneath the spinal cord, and so because they're all close, the preganglionic axons are typically very short, and again they're shown in red. The one exception is the one that runs all the way to the adrenal medulla, but that's the one exception. So the sympathetic division has short preganglionic axons, which originate from T1 to L2. Then again, as I mentioned, notice that the ganglia are all relatively close to the spinal cord with the exception of the adrenal medulla, but the chain ganglia and the collateral ganglia are close to the spinal cord. And so because they're close to the spinal cord, those short preganglionic axons, so those are short, and then the postganglionic axons are going to have to be long to go out and reach the target organs. And those are shown in this image as the black neurons. And so because they go out so far and they're long, they have a chance to branch. So one of these postganglionic neurons may innervate dozens of targets. So just for example, if you pick this little black ganglionic neuron right here and you look at its axon, you can see that it can branch and go off into multiple directions and innervate multiple targets. So let's look at the functions of the sympathetic division. And keep in mind that we typically in A&P these days, we just use epinephrine and norepinephrine. The older forms of these words were adrenaline and noradrenaline. So whenever you do see adrenaline or noradrenaline, adrenaline is the same thing as epinephrine and noradrenaline is the same thing as norepinephrine. So you get heightened mental alertness with the sympathetic division. You also get dilation of your pupils to let in more light to help you see better and to prepare to respond to an emergency. Again, when you're going through these, think of all of these as helping you with that fight or flight response. So you have an increase in your metabolic rate, which actually means you're going to increase your production of ATP. And again, that's going to prepare your body for action. You're going to have reduced digestive and urinary functions. So you're going to have inhibited salivation, inhibited activity of the stomach, inhibited gallbladder, inhibited activity of the intestines, and the bladder will actually relax. This is why some people, when they get really scared and they have this fight or flight situation kick in, they actually can just let their bladder go. And you see this in dogs a lot too. With the sympathetic activation, they can actually end up peeing themselves, and because of the relaxation of the digestive functions, in more extreme cases, you can even poop yourself as well. The sympathetic division also activates your energy reserves, so you are going to stimulate the release of glucose into the bloodstream, as well as increase the release of lipids into the bloodstream from your adipose tissue. You're going to increase your respiratory rate, and you're also going to dilate the respiratory passageways. So this is what it means over here when it says relax airways. This allows the passageways to become larger, which allows more air and oxygen to get to the lungs. And this is why an EpiPen is given when a person has an allergic reaction that stops their breathing. And an EpiPen is just an injection of epinephrine. And we're going to talk about specific neurotransmitters a little bit later, but epinephrine and norepinephrine are two of the key neurotransmitters in the sympathetic division. You also get an increased heart rate and blood pressure. You activate your sweat glands. And the sympathetic division is responsible for orgasms. Now, the complete sexual response needs both parasympathetic and sympathetic activation, as we'll see when we get to the parasympathetic part. So when we talk about sympathetic activation, so that term actually refers to the response of the entire division at once. So you can have smaller responses that are ongoing. For example, you can dilate your pupils without having an increase in heart rate, right? And you can have an inhibition of your salivation without, having your bladder relax. So you can have pieces of the system that are doing different things at different times to keep your body in a homeostatic balance. But when we use the term sympathetic activation, we're talking about a response of the entire sympathetic division at once. And this is truly what we mean when we talk about your fight or flight response. This is when you have an increased alertness, that feeling of being on edge. This is because you also get stimulation of the reticular activating system in your brainstem. You have a feeling of energy and euphoria and a temporary insensitivity to pain. So some people in these emergency situations can hurt themselves quite badly and not even be aware of it until afterwards, after the epinephrine and norepinephrine start clearing out of the system. And people who are so-called adrenaline junkies actually seek out this feeling, so they do dangerous things just to try to get this high. You get an increased blood pressure, heart rate, breathing rate, and a depth of respiration. You get an elevation in your muscle tone, so to prepare your muscles for action. But this can also lead to shivering and shaking. So if you've ever been super nervous or super tense over a particular situation and your hands start shaking, that's because of the sympathetic activation. And you also have mobilization of your energy reserves. So you're breaking down your glycogen into glucose. Remember, glycogen is a stored form of glucose. And you're also releasing lipids from your adipose tissue into the bloodstream so that you have that readily available energy source. So basically, your body is preparing to literally fight or flee. So in this section, we will look at the parasympathetic division, which is your rest and digest system, which predominates during your normal resting conditions. So let's take a look at an overview of the parasympathetic division. So notice that with this division, the preganglionic fibers are going to originate in the brainstem, specifically cranial nerves 3, 7, 9, and 10. And then it's also going to originate down in the sacral segments S2 to S4. Note that of all of these initiating points of the parasympathetic division, the vagus nerve, which is cranial nerve 10, actually contributes to the majority of the parasympathetic system output. So about 75% of all parasympathetic fibers are going to originate with the vagus nerve. The ganglia, which is where the preganglionic fibers go to, is actually located near or within target organs in the case of the parasympathetic system. So this is very different from the sympathetic system. In the sympathetic system, the ganglia were located near the spinal cord. In this division, the ganglia are located farther away, either very close to or inside the target organ. So there are two primary types of ganglia. A terminal ganglion is located near a target organ, And your textbook gives a few examples like the ciliary ganglion, the submandibular ganglion, the otic ganglion. I'm not going to require you to know these names. Just know that a terminal ganglion is one that is located near the target organ. And then an intramural ganglion is one that is actually embedded inside of the tissues of the target organ. So, for example, the vagus nerve is going to go and communicate with a lot of different ganglia that are embedded inside the organs of the abdominal pelvic cavity. So because you have this long preganglionic fiber that is going to a ganglion that is very close to the target organ, the effects of the parasympathetic division are much more targeted than with the sympathetic division. Because the sympathetic ganglia lie close to the spinal cord, they had a lot of time to branch out to go to different targets. Whereas because the ganglia here are so close or even inside the target organ, they don't branch, and so they are very much more targeted to the organ that they are talking to. So here's another picture to take a look at this. So again, notice that the preganglionic axons, shown in red, are originating in the brainstem and in the sacral region. So specifically, they are in cranial nerves 3, 7, 9, and 10. And then they're in the spinal segments S2 to S4. And the preganglionic axons are going to be long because the ganglia are farther away from the spinal cord. In fact, the ganglia are either inside or adjacent to the target organs. So for example, in the case of the ciliary ganglion, that is a ganglion that is very close to the eye, and the eye being the target organ. In other cases, like with the lungs and the heart, you can see the ganglion, which is the yellow circle here, is actually inside the organ. So the ganglia for the lungs is inside the organ, the ganglia for the liver is inside the organ, for the stomach it is inside the organ, etc. So that's why you have a long preganglionic axon, because it has to travel all the way to the organ. Also, because the ganglia are already near or inside an organ, the postganglionic axons, shown in black, are very short, right? So because the ganglia is already where it needs to be, the axon that comes out of the ganglia can be very short to talk to that particular target or organ. So one neuron will innervate a very specific target. So the neuron that leaves the ganglion in the stomach is only going to talk to the stomach. So the functions of the parasympathetic division include constriction of the pupils, a decreased metabolic rate, which means a reduced production of ATP, a decreased heart rate and blood pressure, constriction of the respiratory passageways, increased secretion of salivary glands and digestive glands like the gallbladder and the pancreas, increased motility, which means movement of the muscles in the digestive tract. So for example, the muscle movement that moves your food through the digestive tract is called peristalsis. So the parasympathetic division will increase peristalsis. It will also increase blood flow to the digestive tract to help with the absorption of nutrients. You'll have an increase in absorption of nutrients by cells. And you'll have stimulation of urination and defecation, and this is going to be voluntary. So even though the picture over here says contract bladder, that's going to be contracting the bladder when you decide to go to the bathroom. It's not a case of you just let your bladder go like with the sympathetic division. This division actually controls basically what you consider your normal processes of urination and defecation. And then the parasympathetic division is also responsible for sexual arousal and erection of the erectile tissues in both males and females. And so, as I mentioned earlier, the overall sexual function requires both systems. The parasympathetic division is necessary for the arousal and erection, and then the sympathetic division is what controls the actual orgasm. So we talked about sympathetic division activation, where the entire system got activated at once. You don't really have that with the parasympathetic division because the parasympathetic functions are kind of like the default resting functions, so they should be normally activated anyway unless there's an emergency, and then they switch over to the sympathetic nervous division. So the parasympathetic division is focused on relaxation, food processing, and nutrient absorption. And so homeostasis, or the normal regulation of all of your bodily functions, is actually a delicate balance between both of these branches. So between the sympathetic activity during your fight or flight response and the parasympathetic activity during your rest and digest. And sexual activity is a good example of how both of these branches work together. One branch, the parasympathetic branch, is responsible for the arousal and erection, whereas the sympathetic branch is responsible for the actual orgasm. In this section, we're going to focus on the two major neurotransmitters used by the autonomic division and their receptor types. So remember, a neurotransmitter's results on the postsynaptic cell is dependent on the properties of the specific receptor, and this was covered in Chapter 12. So the first major neurotransmitter we're going to talk about is acetylcholine. Acetylcholine is released by cholinergic neurons. The effects of acetylcholine are very brief because there is a rapid breakdown in the synapse by acetylcholinesterase. Acetylcholine that diffuses out into tissues can also be broken down by an enzyme called tissue cholinesterase. There are two major types of acetylcholine receptors. The first type is called a nicotinic receptor. The nicotinic receptors are found at neuromuscular junctions, as we talked about in Chapter 10, as well as the sympathetic and parasympathetic divisions of the autonomic nervous system. So back in Chapter 10, when we were talking about the ion channels that opened at the motor end plate, those were actually nicotinic receptors. So now you know the official name for them. So nicotinic receptors do open ion channels on the postsynaptic membrane, and so they have the ionotropic or direct effect. So go back to Chapter 12 to review the different types of neurotransmitter effects. There's two major categories, ionotropic and metabotropic. And so with the nicotinic receptors, just like we saw at the neuromuscular junction, you get excitation of the target cell. So you get a generation of an action potential in the target cell. The other type of acetylcholine receptor is called a muscarinic receptor. These are found in primarily the parasympathetic division of the autonomic nervous system. These are a metabotropic type receptor, meaning that when the neurotransmitter binds, you're going to get activation of a second messenger cascade inside the cell, which can eventually lead to opening of ion channels. So muscarinic receptors can be either excitatory or inhibitory depending on the subtype. So there are actually 5 subtypes of muscarinic receptors called M1 to M5. We're not going to go into this level of detail. Just know that the muscarinic receptors can either be excitatory or inhibitory depending on which subtype is activated. Just for your information, both of these types of receptors were named for toxins that bind to them. So nicotinic receptors were discovered because this is where nicotine binds. Nicotine is found in tobacco. And the muscarinic receptors were named because they found that this is where muscarine, which is a compound found in toxic mushrooms, binds. So the second major neurotransmitter of the autonomic system is norepinephrine. Norepinephrine is released by adrenergic neurons. So adrenaline is the same thing as epinephrine. Noradrenaline is the same thing as norepinephrine, which is why you still see, we're calling it norepinephrine and epinephrine these days, but we still get the holdover in terms of like the neuron name being adrenergic. The effects of norepinephrine last longer than acetylcholine. Norepinephrine can be reabsorbed and reused by the neurons that release it. It can also be reabsorbed and broken down by an enzyme called monoamine oxidase, or MAO. It can also be broken down in tissues by catechol-methyltransferase, or COMT. You might recognize these in a lot of the drug commercials that you see on TV or hear on the radio, and when they run through all of those side effects really fast at the end, they usually say, don't take this if you're taking an MAO inhibitor. So this is what they're talking about, this particular enzyme. Note that the effects of epinephrine and norepinephrine that is released directly into the bloodstream by the adrenal medulla last even longer because there are no enzymes in the bloodstream to break these compounds down, so their effects last much longer. There are two types of norepinephrine receptors, and both are metabotropic, meaning that they involve the second messenger pathway within the cell. So the first type is called alpha receptors. There is an alpha 1 receptor, which is the most common type of alpha receptor, and it has an excitatory effect on the cell. There is also an alpha 2 receptor, which has an inhibitory effect, and this usually involves pathways that are going to inhibit parasympathetic activity. So as you're going to see in a few minutes, norepinephrine is mainly used by the sympathetic nervous division. So because the sympathetic division is active, it wants to inhibit actions by the parasympathetic division. Then there are also beta receptors. The beta 1 receptor increases metabolic activity and heart rate, which can increase blood pressure. The beta 2 receptor is inhibitory, and so its inhibitory role is usually to cause muscle relaxation, specifically smooth muscle relaxation in the respiratory tract. So this allows dilation of the passageways going into the lungs. There's also a beta 3 receptor found in adipose tissue, and stimulation of this receptor causes the breakdown of stored triglycerides or stored fat. Note that epinephrine can stimulate both alpha and beta receptors, whereas norepinephrine primarily stimulates alpha receptors. You may have heard of a drug called a beta blocker. Beta blockers typically block the beta 1 receptors, although there are some beta blockers that can block B2 or B3. But typically the beta blockers block beta 1, and they're given to patients to lower their blood pressure. So if beta 1 increases heart rate and blood pressure, blocking it will lower the heart rate and blood pressure. Beta blockers are also given to treat anxiety, but we don't know the mechanism behind how that works yet. And then asthma inhalers usually target beta 2 receptors. So remember, beta 2 receptors allow for the muscle relaxation in the respiratory tract. So in this case, the asthma inhalers are not blocking it, they're actually triggering it so that the respiratory passageways will open. All right, so those are the two major neurotransmitters. Now let's see where they can be found in the autonomic nervous system. So we have our sympathetic nervous system picture on the left. We have our parasympathetic nervous system picture on the right. Remember, in the sympathetic division, we have short preganglionic neurons. We have the ganglia that are typically located close to the spinal cord, and we have much longer postganglionic fibers. In the parasympathetic system, we have long preganglion neurons. The ganglia are close to the target organs, and so we have very short postganglionic fibers. So in the sympathetic division, the preganglionic neurons are going to release acetylcholine at their synapse, and the postsynaptic cells in the ganglion neuron are going to have nicotinic receptors. So sympathetic system at the ganglion, we're releasing acetylcholine, and that's binding to nicotinic receptors. Then the postganglionic neurons in their synapses, when they're talking to the target tissue, are going to release mostly norepinephrine. And then if we look at the parasympathetic division, the preganglionic neurons is the same thing. They are going to release acetylcholine, and the ganglionic neuron is going to have nicotinic receptors. So that is the same between both divisions. But then in the parasympathetic system, the postganglionic fiber is also going to release acetylcholine, but this time it's going to bind to muscarinic receptors. So here is another picture to help summarize the information for you. This one doesn't show the differences in lengths of neurons, but I like the way that it shows the neurotransmitters and receptors better. So you have the sympathetic nervous system on the left, the parasympathetic nervous system on the right. Notice that in the ganglia, so the ganglia is this orangey colored ball. In the ganglia of both, you have acetylcholine being released from the preganglionic axon, and it's binding to nicotinic receptors on the ganglionic neuron, right? So that's the same between both. Then when we get out here to the target tissue, the sympathetic postganglionic neuron is releasing norepinephrine, which is going to bind to an adrenergic receptor, and this can be an alpha or a beta receptor. And then in the parasympathetic nervous system, the postganglionic neuron is releasing acetylcholine, which this time is going to bind to a muscarinic receptor. So before we leave this section, a brief message about nicotine poisoning. So nicotine, which is found in tobacco and tobacco-containing products, targets the autonomic ganglia of both autonomic divisions. So notice you have nicotinic receptors, which nicotine binds to in both the sympathetic nervous system and the parasympathetic nervous system. And as I just mentioned previously, the nicotinic receptors are also at the neuromuscular junction of skeletal muscles. So nicotine is going to bind there as well. So nicotine poisoning can occur with as little as 50 milligrams of nicotine ingested or absorbed. So you get widespread autonomic activation of both the sympathetic and parasympathetic nervous systems. This leads to vomiting and diarrhea, high blood pressure, rapid heart rate, sweating, profuse salivation. These are usually some of the key characteristics of nicotine poisoning. You also can get convulsions of the skeletal muscles from activation of the nicotinic receptors at the neuromuscular junction. So basically the muscles are just going to start contracting all over the place. And then you also have nicotinic receptors inside the brain. So everything up here, we're talking about periphery, but you also have nicotinic receptors inside the brain, and that can lead to coma and death. So people think that vaping is safer than cigarettes because it doesn't have the smoke. And while it's true that the smoke and ash from cigarette use could cause lung cancer, and so the vaping that doesn't have the smoke is safer in that way, but vapes still have nicotine. So cases of nicotine poisoning are actually increasing with the rise in e-cigarette use. Nicotine is also addictive because it increases dopamine release inside the brain. And we're going to talk a little bit later about how drugs become addictive. So it's actually better just to never get started with either smoking cigarettes or smoking e-cigarettes in the first place. In this section, we'll look at dual innervation and autonomic tone. So we're going to focus on targets receiving both sympathetic and parasympathetic commands, and we'll also briefly talk about targets that get just sympathetic commands. So dual innervation refers to when a target gets commands or is innervated by both the sympathetic and parasympathetic divisions of the autonomic nervous system. A good example of this is the heart. So the parasympathetic division, through release of ACH at the postganglionic axon, is going to reduce heart rate. And remember, this is going to be at a muscarinic receptor. And the sympathetic division, through release of norepinephrine at the postganglionic axon, is going to increase heart rate through alpha and beta receptors. And the parasympathetic division is going to dominate during resting conditions. So the sympathetic division is only ever going to dominate or take over during emergency conditions. So here is a snippet from table 16.3 in your textbook. and it's going to show the structure. It's going to show what the sympathetic effects are, including the receptors, and the parasympathetic effects, which are all going to be muscarinic receptors and using acetylcholine. Another good example is in the lungs. The sympathetic system, through activation of beta-2 receptors by norepinephrine, is going to increase the airway diameter of the bronchioles in the lungs, whereas the parasympathetic system, through action of one of the muscarinic subtypes, is going to decrease the airway diameter in the bronchioles. So this is what we refer to as dual innervation. Table 16.3 in your textbook shows what target tissues each division innervates, and you can actually see by looking at this table that the sympathetic division innervates far more targets than the parasympathetic system does. So you should know things that are innervated by the sympathetic division but not the parasympathetic division. These include your sweat glands, your erector pili muscles, which are the little muscles that raise your hairs up. They also give you goosebumps. Your blood vessels, your adrenal gland, the posterior pituitary gland, mucus glands inside the respiratory system, skeletal muscles, and adipose tissue. So all of these structures here get commands from the sympathetic division, but not the parasympathetic division. And then you should also know that autonomic tone is the background activity that is occurring in autonomic neurons. This is very similar to how we talked about muscle tone being sort of the level of muscle contraction that you have at rest. And so that's very similar to this situation, where it's basically the amount of activity you have in these neurons at rest in any given moment. It's called autonomic tone. So autonomic tone is important in both the dual innervation situations, but it's actually even more important when there is not dual innervation. So we'll take a look of an example of each. So in an example where we have dual innervation, like with the heart, so the heart gets fibers from both the sympathetic nervous system and the parasympathetic nervous system. And so there is a background release of both norepinephrine by the sympathetic neurons and also acetylcholine by the parasympathetic neurons. And so at rest, your parasympathetic nervous system is actually releasing more acetylcholine than the sympathetic nervous system is releasing norepinephrine, and this is going to reduce your heart rate and bring it down to your resting heart rate. But because you have the constant release of both neurotransmitters, so the neurons are already active and they're already releasing neurotransmitter, this allows the body to quickly and precisely make changes when needed. So in increasing suddenly the amount of norepinephrine and suddenly decreasing the amount of acetylcholine, you can get a rapid and precise increase in the heart rate. So you don't basically have to get these neurons up and running. They're already running, and all you have to do is adjust the amount of neurotransmitter they're releasing. An example of where autonomic tone is important when you do not have dual innervation is with the blood vessels. So with the blood vessels, which are innervated only by the sympathetic division, you have this background release of norepinephrine. And this keeps the smooth muscle cells partially contracted, so your blood vessels at rest are kept at half of their possible diameter, right? So blood vessels can get larger with dilation, or they can get smaller with constriction. And so this background release of norepinephrine is going to keep them at about half of their possible diameter. So this means that, again, changes can be quickly induced in one direction or the other. I can reduce my release of norepinephrine, which will cause them to dilate, or I can constrict or increase my release of norepinephrine to cause them to constrict even more. So again, by having the neuron already there and active, I can make quick changes in either direction. In this section, we'll look at autonomic visceral reflexes and then regulation of the autonomic system based on higher levels of control. So a visceral reflex is an autonomic response that can be modified, facilitated, or inhibited by higher brain centers. The visceral reflexes have a very similar arc as we saw before when we looked at spinal reflexes. So it starts off with some type of sensory receptor in the periphery. Then you get activation of a sensory neuron, also called an afferent neuron. Then it's going to go to a processing center that's going to involve interneurons. And then in the case of the visceral reflexes, because this is the autonomic system, we don't just have one motor neuron, we have two. So we have a preganglionic neuron or a ganglionic neuron, and then we have a postganglionic neuron. So this is one of the biggest differences between this type of reflex and the type you covered before. And then the same as before, you have a response by a peripheral effector, whereas the reflexes we looked at with the spinal column were skeletal muscle effectors. These will be cardiac muscle, smooth muscle, or glands. So there are two types of visceral reflexes, long and short. The long reflex is very similar to the polysynaptic spinal reflex that we looked at before, with the exception that we have the two motor neurons. That's the only difference. We still have the sensory receptor, the sensory fiber that goes into the spinal cord, into the dorsal side of the spinal cord. It's going to synapse onto an interneuron. The interneuron, in this case, is going to synapse onto a preganglionic neuron, which is going to connect to a ganglionic neuron, which is going to send out a postganglionic axon to the effector. So information processing for the long reflexes occurs in the spinal cord, and it has both the preganglionic and postganglionic motor neurons. The short reflexes bypass the central nervous system entirely. So the information processing by the interneurons actually occurs inside the autonomic ganglia. So the sensory neuron doesn't even go to the spinal cord. It instead goes to the autonomic ganglia, where it's going to synapse onto a interneuron that is inside the ganglia, which is then going to activate a postganglionic motor neuron to talk to the peripheral effector. So that is a short reflex, and that is most common in the enteric nervous system. So we won't talk about that one again until we get to the digestive system in chapter 24. Specific reflexes or specific visceral reflexes are going to be discussed as we move through the different system chapters in A&P 2. If you want to see a preview of some of these reflexes, they are listed in table 16.4, but I'm not going to test you on those. So as mentioned before, the hypothalamus controls the autonomic nervous system. The hypothalamus has the autonomic centers of control. But if you remember from chapter 14, the hypothalamus also can communicate with the limbic system, with the thalamus, and even with the cerebral cortex through the limbic system. So because the hypothalamus has these other connections, there are higher levels of control of our autonomic responses. And a good example is like when you get angry. This can trigger your sympathetic nervous system activity. It can make your heart rate increase. It can make your blood pressure go up. You're not actually in an emergency fight or flight situation. You're actually activating the sympathetic nervous system based entirely on an emotion generated by your limbic system. So that's an example of the limbic system affecting the hypothalamus, which then affects the autonomic nervous system. Another example is biofeedback. This is where people can actually learn how to control their heart rate and breathing. So through time and repetition and practice and types of meditation, they can learn to slow their heart rate, slow their breathing rate, and that is at the level of the cerebral cortex and learned control over the hypothalamic functions. I also like this image from your textbook because it kind of summarizes a lot of things that we've talked about over the past several chapters. So, for example, if we start out with sensory receptors in the periphery, we've got short reflexes where the sensory receptors go straight to a ganglionic neuron of the autonomic nervous system and goes straight out to the visceral effectors. But we also have sensory receptors that are going to go up and then go into the spinal cord as part of those somatic reflexes that we looked at, like the withdrawal reflex and the stretch reflex. It's going to go into the spinal cord. It's going to activate a motor neuron, which is part of your somatic system. which is going to go out and cause movement in a skeletal muscle. You've also got sensory input that's going to talk to autonomic nervous systems in the spinal cord, or autonomic nervous system neurons, and it's going to activate those preganglionic neurons, which are going to activate ganglionic neurons, which are going to go out and affect your visceral effectors. And then sensory pathways are also going to go all the way up and be relayed and processed in the brain. So your somatosensory senses, remember, get filtered through your thalamus. Your thalamus determines what you're going to pay attention to and what it's going to filter out. And that information is going to go up to your cerebral cortex. This is stuff like, your touch, pressure, pain, vision, hearing, pretty much everything except smell. And then your visceral sensory information will actually feed back to the hypothalamus. And so I like this picture because it kind of integrates a lot of stuff that we've been talking about. And then we'll do a final little review of the sympathetic nervous system versus the parasympathetic nervous system. So we'll compare and contrast these two before we move on to some higher order functions. So I have a little chart here. So first, if we look at the origin of the preganglionic neuron, in the sympathetic division, this is going to be between spinal segments T1 and L2. In the parasympathetic division, it's going to be cranial nerves 3, 7, 9, and 10, and sacral segments S2 to S4. The location of the peripheral ganglia, so the autonomic ganglia. In the sympathetic system, it's going to be near the spinal cord in the chain ganglia and collateral ganglia. The one exception is the medulla of the adrenal gland. The parasympathetic division, the ganglia are going to be near or within the target organ and tissue. If it's near it, it's called a terminal ganglia. If it's within it, it's called an intramural ganglia. If we look at the preganglionic fiber or axon length, the sympathetic preganglionic axons are short. The parasympathetic preganglionic axons are long. If we look at the preganglionic neurotransmitter and the receptor that it uses, in the sympathetic system, this is going to be acetylcholine, and it's going to bind to nicotinic receptors. And in the parasympathetic system, it's going to be acetylcholine binding to nicotinic receptors. If we look at the postganglionic fiber length, so leaving the ganglion and going out to the target, it's going to be long in the sympathetic system and short in the parasympathetic system. If we look at the postganglionic neurotransmitter and receptor combination, in the sympathetic system, it's going to be mostly norepinephrine, which is going to bind to alpha and beta receptors. And in the parasympathetic division, it's going to be acetylcholine, which is going to bind to muscarinic receptors. So the target area, remember, because the sympathetic system has long postganglionic axons, they can branch and go out to multiple target areas, so it has a broad target area. Whereas in contrast, the parasympathetic division has those short postganglionic fibers, so it doesn't have room to branch and go to different places, so it's going to be highly specific for its target area. And the general function, the sympathetic, is our fight or flight, so it's going to stimulate metabolism, increase alertness, and prepare our bodies for emergency. Whereas the parasympathetic division is our rest and digest. It's going to promote relaxation, promote nutrient uptake, and promote energy storage. And then this is a picture that used to be in the textbook, but they've since removed it and divided it into two separate images. But I like this image because you can easily compare and contrast the two different systems. You can see the different locations where the preganglionic axons come off the spinal cord. You can see the sympathetic chain ganglia as well as the collateral ganglia. Whereas over on the parasympathetic side, you've got these terminal ganglia that are close to their target, and then all of the rest of the ganglia are actually inside their targets. So you've got very short preganglionic neurons in the sympathetic, so they only go from the spinal cord to the chain ganglia. Whereas in the parasympathetic, all of these neurons, or most all of these neurons that you're seeing, are preganglionic neurons. They go from the spinal cord all the way to the target area, or to those terminal ganglia. And then so you have very long postganglionic neurons in the sympathetic that can branch and go to multiple targets, whereas in the parasympathetic division you've got very short postsynaptic or postganglionic neurons. And in fact, you can't even see the ones in the organs in this image, but they're right there inside the organ, and you can see the short ones up here as well. For the remainder of Chapter 16, we'll look at a few higher order functions, starting with memory. So there are two major types of memory. There are fact memories, which are also included with episodic memories, and these are specific bits of information or memories about things you did, places you went, etc. And these types of memories require the hippocampus in order to store them long term and to retrieve them later. There are also skill memories, what we sometimes refer to as muscle memory. These are learned motor behaviors, and these involve integration of signals from the basal nuclei, the cerebral cortex, and the cerebellum. You can also differentiate between long-term memory and short-term memory, with short-term memory being something that you only hold within your brain for a short period of time, and then it can be permanently lost. But repetition of short-term memories can help to promote retention and turn them into long-term memories. So what exactly are memories? So a memory engram is the term that we use to describe a single circuit within the brain of two or more neurons that correspond to a single memory. So for example, you may have a connection between two neurons that encodes the information that you remember as what a cat is. So a cat is an animal that looks like this, for example. We've actually also narrowed down some memories to just specific single neurons, and I'm posting an interesting article on D2L about when researchers discovered what they called the Jennifer Aniston neuron. So they looked at a bunch of different people's brains and the activity in their brains, and they were able to narrow down recognition of Jennifer Aniston's face to activity in a single neuron. In reality, it's thought that your more complex memories involve connections between multiple neurons, and it starts out in the hippocampus. So the hippocampus has a specific pattern of different neurons that are connected together, and this is what we would consider short-term memory. And then in order to turn that into a long-term memory, the hippocampus takes that pattern and it stores it up in the cortex. So the cerebral cortex, it stores that pattern. It may not look the same, but it actually takes that pattern and stores it long-term into the cortex. And then that is what we refer to as a long-term memory. So do you remember my A&P study help video at the beginning of the semester? I put it in the general course info folder. I know some of you probably didn't watch it, but for those of you that did watch it, this should sound familiar. So back in that A&P study help, I was trying to tell you some things about memory before we actually got into the details within the textbook. And one of the things I mentioned is that we know that neurons that fire together wire together. And in other words, the neurons that make up those memory engrams, the more you use them, the stronger those connections become. So like back in chapter 7 of this semester, or actually chapter 8, you learned that the olecranon was a process that forms the point of the elbow, and it's part of the bone known as the ulna. So that memory engram is an actual physical connection between two or more neurons within your brain. And at first it's a very weak connection, and you have to study the material and repeat it in order to strengthen that connection. But over time you get stronger synapses where you have an increased neurotransmitter release at that synapse. You end up actually developing more synapses, and you even end up growing new axon collaterals and new dendrites to make it a super strong connection. That is when it becomes a long-term memory, and it's easy to pull up at a later period. So again, as I introduced you to in that study help video, This was a graphic that showed that if you're cramming and you're not repeating information, you're not forming very many synapses, and they're not going to be permanent. Whereas if you study 9 to 12 hours per week all throughout the semester, you're forming all kinds of very strong synapses and long-term memories. So the term consolidation is what we refer to as the actual conversion of a short-term memory into a long-term memory. And it actually has anatomical cellular mechanisms that we can see and study. So we know that it involves increased neurotransmitter release at specific synapses. We know that those synapses become stronger, and this is called a process of facilitation. So you get increased neurotransmitter release, you have more receptors on the postsynaptic membrane, and in general, that synapse becomes easier to trigger and pass on messages. You also get the formation of additional synaptic connections. So you get new axon terminals and you get new dendrites. So here is an image from the Nature Neuroscience journal, and I'm not going to go into all of the details, but what I want to show you is they're showing two example synapses here, labeled 1 and 2, and they're showing that over time, those synapses, there are actual physical mechanisms that happen to make those synapses get larger. So if you look down here in C and D, you can see that the spine on the dendrite got larger. You can see that the synaptic terminal of the presynaptic neuron now has more vesicles and now has more neurotransmitter in those vesicles. So over time, those synapses actually strengthen. Repetition is crucial to this process. This is why cramming may get you enough of a short-term memory to do okay on a test, but you're not going to remember the information long-term, like if you go on to nursing school or dental hygiene school or medical school or whatever your next step of your career is. So you have to repeat the information over and over in order to strengthen these connections physically and have that strong memory. Also notice in this same image that synapses can also fade away with disuse. So if a synapse is not used, then over time it will weaken, it will get smaller, you'll have less neurotransmitter release, so it actually goes both ways. So where does this memory consolidation occur? Well, we know that the hippocampus and the amygdala are two structures that are essential for memory consolidation. I'm going to tell you a story about a gentleman who is one of the most famous neuroscience patients, and he had these areas of his brain removed and he could no longer form new long-term memories. So we know that these areas are essential for consolidation. We also know that long-term memories are stored in the cortex, in the cerebral cortex. And we know that there's quite a few other structures that contribute. So we do know the amygdala is key, the hippocampus is key. There are some other areas that play a role. We also know that glutamate is an important neurotransmitter in the learning and memory process. We also know that the nucleus basalis plays an important role. Do not confuse that with the basal nuclei. These are two different structures. But we know that the nucleus basalis plays a role because it's one of the first areas to deteriorate in Alzheimer's disease, in which anterograde amnesia, or loss of the ability to form new memories, is one of the hallmarks. And then the other important thing to point out is that consolidation occurs while you sleep. So lack of sleep or insufficient sleep will also interfere with your ability to form long-term memories. So sleep and repetition are essential, and I mentioned this on the intro video as well, that in order to get these memories and the stuff that you're learning into your long-term memory, you have to allow yourself multiple days so that you can repeat the information, sleep, repeat the information, sleep, repeat the information, and sleep. This is the only way long-term memories are formed. There is no shortcut, no magic pill that allows it to happen easier. And here is an image from another journal that again shows you that as you sleep, these processes are occurring. So while you are sleeping, you go through cycles of slow wave sleep and REM or REM sleep, and we'll talk about that in the next section. But as you cycle through these different stages of sleep, we can map out that there are strengthening connections between the hippocampus and the cortex. We can see that the synapses are either scaled up, meaning they're made stronger, or scaled down, meaning they're made weaker, depending on how often, again, you use those synapses. That happens while you sleep. And so the strengthening of the memories in your cortex also occurs while you are sleeping. And you cycle through these stages all throughout the night. So I briefly alluded to the case of patient HM. He is one of neuroscience's most famous patients. His name is Henry Molaison. We typically don't use patient names until after their death. So prior to his death in 2008, he was just called patient HM. He had the removal of both of his hippocampi and other regions of his temporal lobe when he was only 23 years old. So you can see from this image over here, pretty much this entire lower section of his temporal lobe and where the hippocampus is was removed. And you can see here on the cross section how much was actually removed. And this was done as a treatment for epilepsy. He had very severe epilepsy. And at the time, we had no idea what the hippocampus did. So the doctors were like, oh, seems to be making his seizures worse. Let's take it out. They did not know at that time what the hippocampus does. However, it was shortly noticeable, shortly after the surgery, that HM could no longer form new memories. He had all of his old memories, but he could not make any more new memories. So he had what we call anterograde amnesia, which is the inability to form new memories. So even like he would meet a new researcher or doctor in the morning, he wouldn't remember who they were by that afternoon. There's a brief biography posted on D2L as well as a Nova video. It's about 10 minutes long about HM and what we've learned from him about memory. So he has taught us a lot about memory formation. One of the classic experiments they did with him showed that skill memories don't require the hippocampus. So he was able to learn new motor skills. And this was the first time that we realized that muscle memory or motor skills are stored in a different place in the brain than factual and episodic memories. So without HM, we might not have learned that. The video that I'm posting also mentions PKM zeta, which is a molecule we have recently found that seems to be necessary for the formation and maintenance of long-term memory engrams. If you inject a rat with a blocker for this molecule, you can actually make it forget specific memories. So again, if you want to see more about that, it's in the video. And even more recent news, there's another molecule called FXR1P that seems to block our ability to learn past a certain point. So they're thinking that if we're able to, or find a way to block this molecule, it may allow us to actually store more memories or have sort of a super memory. And I'm posting an article about this one on D2L if you're interested. So I mentioned that memories are stored in the long term in the cerebral cortex, and where that information is actually stored in the cerebral cortex depends on the nature of the specific memory. So if we look at memories about cats again as an example, in your visual areas you'll have memories of what a cat looks like and what the letters C, A, and T look like and that they come together to make the word cat. Your auditory areas will remember what cat sounds like spoken aloud, what a meow sounds like, what a purr sounds like. Your speech areas will have memories related to how to say cat. Your frontal lobes, which is where your factual information is stored, will have the memories like, I know that cats purr, I know that cats have claws, I know that cats are animals called felines. Factual informations would be in the frontal lobes. Your sensory cortex would store memories like the feeling of the soft cat fur, the feelings of claws along your skin. And then limbic areas can store emotional memories like, oh, I love cats, or ooh, I don't, I'm scared of cats. Right? So specific memories are actually stored in different cortical areas. And then last little section here on memory problems. So amnesia is the term we use to refer to the loss of memory due to disease or trauma. And there are two broad classes of amnesia. Retrograde amnesia is the loss of memories of past events. So you can make new memories, but you can't remember old ones. And anterograde amnesia is the inability to store new memories. So you can remember everything that used to happen to you, but you can't make new memories. Senile dementia is a condition that comes along because of age-related changes that lead to memory loss, anterograde amnesia, the inability to form new memories, and emotional disturbances. And one specific type of senile dementia that has taught us a lot about the process of senile dementia is Alzheimer's disease. So this is a specific type of senile dementia, and it involves the accumulation of these structures called tangles and plaques in regions of the brain involved with memory, emotions, and intellectual function. And the cholinergic neurons in the nucleus basalis are usually the first set of neurons to die, which is why we know the nucleus basalis does play some role in memory, although it's not clear exactly the role that it plays. So here's a picture of the brain loss that occurs with Alzheimer's disease. So it actually is a loss of neurons. The neurons themselves die. And again, this death of neurons occurs mainly in areas related to memory, emotions, and intellectual function. And so Alzheimer's patients, one of the first symptoms is usually the loss of the ability to store new memories, the anterograde amnesia, although they may still have good memories of their past life and what happened to them many years ago. And then here is a little graphic to show you the two main characteristics of Alzheimer's. Neurofibrillary tangles are collections of proteins that build up inside the neurons and contributes to their death. And amyloid plaques are proteins that build up outside the neurons and again seems to contribute to their death. In this section, we'll look at states of consciousness, which include sleep and wakefulness. So we're going to start with sleep. There are two major levels of sleep. With deep sleep, the activity in the cerebral cortex is at a minimum. Your heart rate, blood pressure, respiration, and energy use all decline up to 30% of normal. And then there is a type of sleep called REM sleep, or rapid eye movement sleep. And the activity in the cortex during this stage is very similar to a wakeful state. Heart rate, blood pressure, and respiration change frequently, usually depending on what you are dreaming. And this is the period in which you do dream, whether you remember it or not. And there is intense inhibition of the somatic motor neurons to prevent you from acting out these dreams. So people who have sleepwalk, for example, typically have a loss of this inhibition. And if you look at the EEG down here at the bottom, you'll see that during REM sleep, the EEG activity looks very similar to during the awake state. And then during deep, slow wave sleep, it looks very different. And then as you sleep through the night, you actually cycle through these different stages. So after you first go to bed, you will generally go through a quick stage of REM sleep into a longer period of deep sleep. Then you'll cycle back up and down again. And then as the night goes by, you spend less time in deep sleep and more time in REM sleep. So we know that sleep is very, very important. If you give an animal total sleep deprivation, it will become fatal within weeks. And then if you also do an experiment where you deprive an animal of just REM sleep, that is also fatal. So we know that sleep and REM sleep are very important. So there are a lot of health conditions that are linked to a chronic lack of sleep, including obesity, heart disease, blood pressure, high blood pressure, diabetes, a shorter lifespan, and even Alzheimer's disease, beta amyloid plaques. And I'll mention that again on the next slide. Here is a chart that shows all of the consequences of inadequate sleep. And this will give you some of the indications of all of the different systems that it affects, including some of the molecules involved. So for example, A decrease in growth hormone can lead to a decrease in astrocyte activity, which can lead to an accumulation of neurotoxins, which can lead to an increased risk for Alzheimer's disease and Parkinson's disease. You also can end up with an increased risk of obesity, an increased risk of cardiovascular disease, things like insulin resistance and type 2 diabetes, an increase in several types of inflammatory disorders, even an increase in risk of cancer. So lots of bad health outcomes are linked with inadequate sleep. Even just getting one night of too little sleep is linked to increased levels of inflammation and increase in hunger promoting hormones, which tends to cause you to crave sweet and fat foods. So if you don't take my word for it that sleep is very important and essential for good health, maybe you'll believe Halle Berry and Jennifer Lopez. So here's a picture of both of them in their 50s. And when asked about one of their beauty secrets in several magazine articles I've seen, they both say they make sure they get 8 to 9 hours of sleep every night. So sleep is vitally important. So why do we need sleep? So what I'm about to talk about is what takes place in the central nervous system. But remember, we also talked in an earlier chapter about how melatonin production can also repair many of your body systems while you're sleeping. So that's another benefit. But why does the CNS need sleep? There are three main hypotheses, and the final answer is that it's actually probably a combination of all three. So one is that we sleep to forget. So we actually create multitudes of new synapses every day, and a lot of it is irrelevant information. Like exactly what shirt did you put on? Exactly what pair of underwear did you put on this morning? What did you have for breakfast? Where did you park your car when you went to the coffee shop? Where did you park the car when you went to the campus? You know, what was the color of the car you were driving behind? I mean, just tons of irrelevant information that gets encoded into our brain. And so each night we sleep to erase the information we don't need to keep the brains uncluttered. The flip side of that is we also sleep to remember. So as I mentioned before, we know that memory consolidation happens while you sleep, and this is the process of strengthening important synapses. So sleep is definitely a combination of these two. So while you're awake, remember the hippocampus is making these new memories and it is encoding them up into the cortex while you're in the sleeping process. But the idea of forgetting means that we also need to clear the slate because we have a lot of junk sticking around, and we also need to get rid of that to make room for the next day's new memory formation process. So when we sleep, we get rid of the most weakly connected memories or synapses, and we strengthen the ones that we spent the most time thinking about. And then the third hypothesis is that we sleep to wash out our brain or brainwash. This is one of the newest hypotheses, and I'm posting an article about it on D2L. And so recent research has shown that our CSF flow actually increases while we sleep. And it's thought that this increase in cerebrospinal fluid flow helps to remove built-up waste products and so helps with house cleaning. And in fact, this is the hypothesis that is linking a chronic lack of sleep with an increased risk for disorders that involve the buildup of proteins in the brain, like Alzheimer's involves those neurofibrillary tangles and the amyloid plaques. And it's thought that part of that can be because you didn't have enough sleep throughout your lifetime to wash those abnormal proteins away. And as I mentioned in the beginning, you probably actually sleep because of a combination of all three of these things going on. And we also know that sleep is important for normal memory. So a lack of sleep will adversely affect your memory, and a lack of sleep will interfere with the ability to learn. So here is one study that looked at the link between sleep and academic performance. And they found that the number of days per week that the student had 5 or less hours in sleep, their GPA would go down. So students who spent most of the week with very little sleep had a lower GPA than students who got more than 5 hours of sleep every night. And then conversely, if they looked at the total number of hours slept in an average night versus GPA, the more hours slept each night correlated with a higher GPA. So bottom line, don't skimp on your sleep. I tried to get that across to you in the study help PowerPoint that I posted at the beginning of the semester, but I'm not sure how many of y'all watched that, but you've got the message now. So in contrast to sleep, you also have wakefulness, which is also known as arousal. So this is not sexual arousal. This is arousal as in alertness. This is awakening from sleep. And this is going to involve the reticular activating system, or RAS. And this is a diffuse network within the reticular formation, which is part of the midbrain. So as we talked about in chapter 14, the reticular formation extends from the medulla oblongata all the way up to the midbrain. And then the reticular activating system is actually the top part of it that is in the midbrain. And it sends signals out to both the thalamus and the cerebral cortex. And your sleep is ended by any stimulus that will activate the RAS. And then the longer you are awake, the more the RAS function decreases. So it's thought that when you've been awake for a long time and you have that sensation of fatigue or that need to sleep, that's because the neurons in your RAS are firing much slower, and that's giving you the fatigue feeling and the drive to sleep. So let's look at the role of neurotransmitters in states of consciousness. So norepinephrine is one of the neurotransmitters that promotes wakefulness, but actually the story is actually a lot more complex than your textbook tries to make it seem rather simple. But in reality, there are several neurotransmitters that promote wakefulness, including serotonin, which your book mentions as a sleep-promoting neurotransmitter. But these neurotransmitters in the left column are all wake-promoting neurotransmitters. And then you've got different neurotransmitter sets for non-REM or deep sleep, and then REM or rapid eye movement sleep. I do want to point out adenosine. Adenosine is a neurotransmitter that promotes sleep. And why does this matter to you? Because you probably have heard of a little thing called caffeine, and caffeine blocks adenosine. Right? So when adenosine binds to its receptor, it makes you feel tired, and it's a sleep-promoting neurotransmitter. So caffeine blocks this receptor, and thereby it delays the fatigue and gives you more of an alert feeling. But as with any drug, you don't want to overdo it. Too much caffeine can lead to nervousness and jitters, nausea, elevated heart rate, anxiety, headache, dysphoria, which is a sad feeling, and then, of course, insomnia, because you're delaying your need to sleep. Just because you take caffeine to stay more alert does not mean your body is getting the benefits that it would get if you went to sleep. So it is better to sleep if you can. And then I mentioned this in chapter 14, but there's an area of the hypothalamus called the preoptic area. And a lot of times when you look at diagrams like this, you'll see it also referred to as the VLPA or VLPO, which is the ventrolateral preoptic area. And this is an area within the hypothalamus that serves as like a sleep switch. And so there's this idea that your brain goes back and forth. So when the region in the hypothalamus is inhibited, then the other brainstem and reticular activating systems are activated, and they release all of these neurotransmitters like acetylcholine, norepinephrine, serotonin, and histamine, and that leads to an alert waking state. And then when these systems are inhibited, the preoptic area of the hypothalamus is activated, and so now you have reduced neurotransmitter release and you have slow wave sleep. And so there's a mutual inhibition between these two systems. So when one is on, the other's off, and when one is off, the other's on. So we call this like a flip-flop circuit or a sleep-wake switch. And so in the last section for this chapter, we'll just look at the influence of three neurotransmitters, serotonin, norepinephrine, and dopamine. And then we'll just briefly talk about the mechanism behind addiction. So serotonin can affect mood, cognition, learning, memory, temperature regulation, and vasoconstriction. In fact, its roles in causing blood vessel constriction was actually how it was first discovered. So the name serotonin, tonin actually means to constrict or to increase tone, and sero refers to the blood. So the fact that it causes vasoconstriction was actually how it was discovered. Serotonin is produced by neurons in the brainstem called the raphe nuclei. And so in this image here, you can see the raphe nuclei spread throughout the brainstem. It's these dark areas. And then the serotonin neurons that originate in these areas then go all through the cerebellum and the cerebrum and the limbic system of the brain. If you have too much serotonin, this can cause sensory processing disturbances. For example, LSD activates serotonin receptors and causes hallucinations. And then there's a condition called serotonin syndrome, which we are increasingly aware of because of the number of drugs on the market that affect serotonin. And this is an elevation in body temp, like a fever, but without a cause, as well as agitation, tremor, dilated pupils, diarrhea, increased reflexes, and sweating. If you don't have enough serotonin, this is linked with depression and anxiety. And there are drugs on the market called selective serotonin reuptake inhibitors, or SSRIs. These drugs block the reuptake of the serotonin out of the synaptic cleft once it's been released. So it increases the length of time that the serotonin stays in the synapse. Some example brand names are Prozac, Celexa, Luvox, Paxil, and Zoloft. Norepinephrine can increase arousal and alertness. It can promote vigilance and attention. It can enhance the formation and retrieval of memories, but it can also increase restlessness and anxiety. So this is the role of norepinephrine in the brain. We talked earlier about its role in the autonomic nervous system in the periphery, but now we're talking more about its role in the brain itself. So it is produced by neurons in the brain stem called the locus coeruleus. And so it's this little area shown in the blue circle. That is the noradrenergic neuron origination point. And so from this point, the neurons send their axons again all throughout the cerebrum, the limbic system, and the cerebellum, and even down to the spinal cord. So drugs that increase the release of norepinephrine within the brain lead to exhilaration. And drugs that block norepinephrine release can result in depression. So we're now finding out that norepinephrine plays a larger role in your mood than was previously thought. So now on the market, there's a new class of drugs called norepinephrine reuptake inhibitors, NRIs, and also combination serotonin and norepinephrine reuptake inhibitors, or SNRIs. And these are both drugs that are also used to treat depression. Cymbalta is an example SNRI, and Wellbutrin is an example NRI. Dopamine plays a role in motor control and the reward pathway. It is produced by neurons in the brainstem in two areas, the substantia nigra and the ventral tegmental area. So here in this picture, you can see the two places in the brainstem, the substantia nigra here and the ventral tegmental area here. So we've already talked about the substantial nigra and how it plays a role in motor movement. And so the dopamine neurons go up to the basal nuclei. But the ventral tegmental area plays a role in the reward pathway. So this is the area that's going to be affected more by drugs that cause addiction. So if you lose dopamine, this can result in Parkinson's disease. Specifically, you lose the dopaminergic neurons in the substantia nigra. But if you have too much dopamine, this can cause schizophrenia. And schizophrenia is a behavioral disorder that's marked by pronounced disturbances in mood, thought patterns, and behavior. And the reward pathway that centers around dopamine is actually commonly targeted by recreational drugs. So if we just look at the reward pathway, this is going to be the ventral tegmental area, so the VTA in the brainstem. There's also an area called the nucleus accumbens, which plays a large role. and then of course the prefrontal cortex. So this circuit here is typically referred to as the reward circuit or the reward pathway. So let's just introduce you to the idea of addiction and what happens. So addiction usually always involves drugs that affect the dopamine reward pathway in one way or another. So all of the following can affect the dopamine reward pathway. And so before I read off this list, I'm going to explain this picture. You don't have to memorize this picture or anything, but this is just to give you an idea. So those three areas that I just mentioned to you were the ventral tegmental area in the brainstem. We had the nucleus accumbens, and we had the prefrontal cortex. And the combination or the connections between these three make up what we call the reward pathway. And so all of the following drugs can interact with this pathway at one or more points. So cocaine and crack can interfere with the nucleus accumbens and the prefrontal cortex. Heroin and other opioids can interfere with the nucleus accumbens and the ventral tegmental area. You get the idea. The picture here shows where the different drugs interact with the different parts of the pathway, but other addictive drugs include nicotine, alcohol, amphetamine and methamphetamine, ecstasy, and cannabis. So the more addictive a drug is, the more physical changes that it causes along this pathway. And the most addictive drugs actually cause a reduction in the number of dopamine receptors. So remember, neurotransmitters do their job by binding to receptors. So if you reduce the number of receptors, then the neurotransmitter release is not going to cause as big of an effect as it did. So with a lot of these drugs, particularly like the methamphetamines, the heroin and opioids and cocaine and crack, they actually cause a reduction in the number of dopamine receptors. And now that you have fewer dopamine receptors in this pathway, even things that would normally be considered pleasurable, like eating a piece of chocolate or even having sex or looking at a beautiful sunset, things that you typically enjoy, once your dopamine receptors have been reduced, these things don't bring as much pleasure as they used to, and everything feels kind of dull and gray. And so the person has to require the drug just to feel normal, and then they have to take higher and higher doses of the drug to get the high that they got the first time they took it. And this is a process called tolerance. And so here is an image. This is showing dopamine receptors, and you can see the difference. This is a dopamine receptor availability. So red means more, and blue down here means less. And so in a non-drug user, you can see nice available dopamine receptors, and in this MRI from a cocaine abuser, you can notice the difference, how you have far few dopamine receptors that are available. And that's what makes these drugs so addictive, because at some point you have to take the drug just to feel normal, never mind getting the high again. So I'm going to put a link on D2L to a little animation series called Mouse Party. It's got several mice that are addicted. These are animated mice, not real mice, but they are addicted to different drugs of abuse. You can pick them up and place them in a chair and take a look in their brain. So it's a cute little animation that gives simplified explanations behind how recreational drugs affect brain chemistry if you're interested in learning more details about these different drugs. And then my final message is that with time and abstinence, you can get your dopamine receptors to come back close to how they started, but it does take time, and it's a hard process. And so in this particular image, you can see, and again, a normal person's dopamine receptors here at the top. And the second image is a methamphetamine abuser. Even 1 month after stopping, they still have far, far fewer dopamine receptors than they should. And it takes almost a year and 2 months, so 14 months later, before their dopamine receptors start looking like they did to start with. So the road to recovery is long, and it's hard, and it takes a lot of willpower, because your brain is telling you that you need that drug to feel normal again. So if you haven't started drugs, don't. And if you have, know that you can go through a recovery process. It can be difficult, but there are a lot of support systems out there to help you. And that is the end of Chapter 16 and the end of the A&P1 semester material.